Okay, Chapter 5, Communications and Documentations. Now, when we talk about communications, we need to talk about how we communicate during a call, before the call, after the call, all of this type of thing. And it's not something that we can just willy-nilly take up, right? The dispatcher has to communicate the location to the responders. EMRs need to communicate with the patients, the bystanders, the family members, the dispatchers, members of the public safety community, and on it goes. And then following that, after the call, and we talked about this in the Med Legal, you're going to need to write a report so that you can do the handoff information to the next level EMS care and to record it for your agency. Now, we need to send information, right? That's the whole point. Face-to-face is way easier. If I can see somebody, rather than talking to them on the radio, why don't I go talk to them face-to-face? But sometimes that's not possible. And so we'll have to rely on a communication system, right? Whether that be a computer system or a radio, right? You need to know how these things kind of work so that you can troubleshoot it when the problem comes up. There are two categories, and typically speaking, we won't do much that transmits data. Our reports will go out over that in the state of Michigan, but we're more concerned, I think, at least initially, with how do we communicate via voice. Now, obviously, everybody says, well, you got a telephone, you've got your cell phone. Absolutely, that's a great voice communication, but we don't really use that in a large-scale way. We use radios. Now, when we talk about the voice system, we're trying to talk to each other using radios so that we can convey information or orders or whatever else. These radio systems are regulated by the Federal Communications Commission, the FCC. They're monitored, and there's certain rules and regulations that you have to abide by. Appropriate language is definitely one of those things. Now, when we talk about the actual equipment itself, there's four main components here. You've got the main base station radio. That's the one that's got the most power to it. It gets the farthest away. Okay, it sends it out into the universe and is grabbed by either a mobile or a portable. Now, the mobile radios are devices that are mounted in trucks and cars and engines and rescues and things. So they're the ones that are drawing power from the unit itself, and they are powerful, but not as powerful as a base unit that's tied in at a station or so forth. A portable radio is what you see here by this rescuer that's talking on the radio here. This one here is the least powerful out of all of the radios, and it is. But the bonus part is you can be directly at the patient's side or right into the scenario, the call itself, and be able to give communications out. Now, because that portable radio is not so powerful, there might be a repeater in the area. For instance, when I used to work on an ambulance, that the radios we weren't sure if would hit out if we had our portable radios. So our portable radios transmitted to our truck, which then repeated the message out. So it's almost simultaneously. There is a slight delay, but my signal goes to the truck, which is then boosted and then sent out to the antennas and radio towers, and that might be boosted and sent out again, or it might make its destination. Of course, we have the telephone systems, right? We've got, it's primarily to send voice communications, right? Most cell phones now have the ability of doing like a FaceTime or a video chat. Better to see, especially if there's something to look around. But just like HIPAA, got to be careful about what you're sending and who's receiving it on the other side. Landline system phones, typically speaking, while there's still quite a bit of that, they rely on computers now for boosts and so forth. Gone are the days of the analog system where you could use a rotary phone or something like that. But these tied together phone lines or phone signals are a combination of above and below ground hardwired systems. Nothing to do really with radio signals and so forth. And so there you go. I mean, those are your ways of communications. Now, we also have systems that we can send data through. We call them the mobile data terminals, the MDTs. Those are becoming a thing that we do now, and especially in pre-plans and so forth. But these MDTs, they allow for us to be alerted through the computer system, and they automatically keep a log of what's going on. It's pretty interesting stuff. If you still need to send something, yes, fax machines are still a thing, though they are dwindling quickly because you can scan and email them out there. Telemetry is used mostly by ALS to send ECGs, but that is another form of communication. And then, of course, we have the email and the text and the social media, and we can use those things, but not typically in the realm of performing our duties. Now, when we talk about the function of the radio, we start with the dispatch information. Now, it can go out over voice, it can go out over text message, it can come out through MDT. We have what's called e-dispatch, and that's a form of MDT, and it comes to our phones as well as it pages out over our pager, and we hear a voice. That e-dispatch also sends a text message about what's going on. Now, the equipment that we use to receive that information is on us to keep up, right? We are not, or dispatch is not held responsible for if nobody answers, especially if our equipment's not charged, not cleaned, not updated and so forth. But we have to, I should say, make sure that we are ready for those calls to come in. And when we get a call and maybe we don't understand what was said, whether it was garbled or they were talking too loud or too soft or whatever, ask to have them repeat the information. Now, be ready to receive that, because if you ask 2 or 3, 4 times, then it's your problem. It's not their problem, and you're making yourself look like a doofus. You're going to have to know how to use maps, because what happens if your GPS fails or you're in an area that doesn't have cell coverage, right? So you need to know how to get there. Now, dispatch might be able to assist you getting in, right? Point you in the right direction. But typically speaking, that's on you. Once they give you the information, you should be able to get there. And you're going to have to learn those things. They may call while you're en route. Dispatchers may call while you're en route and say, updated information, here's something new that's going on. If, for whatever reason, you're delayed, you come across, there's a train, or there's another accident, or maybe your vehicle is disabled somehow, you need to immediately get on the radio and tell them, hey, I've got this problem or that problem, send somebody else. You need to communicate with dispatch when you arrive on scene. Dispatch from 81.4, we're on scene. Okay? It's always good, though, to give a visual scene size up. Dispatch from 81.4, we're on scene, single story house, nothing showing at this time, or one person in the yard, or whatever it is. And the more hazard there is, the more we need to give them an update on what's going on. Especially if we see, we're arriving on scene to a 2-car or a 2-vehicle accident. One vehicle is a large passenger bus. Multiple patients, send all additional resources in the area, right? put a helicopter in the air. We need we need the Department of Public Safety under assault on the roads. We need to have a bulldozer. Whatever you need to call it and let them know what you need. Then you need to get on the horn with the responding EMS units, whoever's coming to transport, and let them know what's going on, so they can start getting ready for it. Now you want to go direct with them, and maybe that's not over the radio. Maybe you're going to call them directly on their cell phones. You want to let them know what is going on and their main complaints, so that they can be ready for any priority one problems, right, that we're going to have as we're coming up to it. And you can even do your handoff report over the radio, especially in the event that you have multiple patients that you're taking care of. We would do the same approach as we do during the patient assessment. We would provide the age and the sex of the patient, the history of the incident, patient's chief complaint, level of consciousness, how you found it. We're trying to get ready to make it quicker for the transfer, right? So that we can open the doors, put the patient in, shut the doors, and off the ambulance goes, right? Obviously, vital signs and so forth. Typically speaking, I have not really done this part to another agency. When I'm talking about this, we're talking directly to the hospital, and it's called a HERN report, a Hospital Emergency Radio Network, and we tell the hospital everything that's going on, right? And then, especially in the event that we have a delayed EMS response, so that the hospital is ready for them to be transferred in there. We typically get medic control in when the EMTs and the paramedics are trying to do specific skills that, while they're inside the scope of practice, aren't part of their standard of care. They don't happen all the time, right? We have to get permission to do these things. Now, after the call is over, after our portion of the call is over, we put the patient in the ambulance and off they go. Then it's time for the report, right? We've turned over the patient, we demobilized, we're back at the station or back at your base or wherever. You need to report the status of you to dispatch. Hey, dispatch from 814, we're back in service, we're back at station. And then you need to get ready for the next call, right? We start getting ready for that next call phase. Here's just a little guideline for effective radio communications. You don't need to say yes, no, or you don't need to say please and thank you. That's assumed. Use plain English, not 10 codes. Lots of things here to cover, and we might spend a moment of time in class, but that's something more for your agencies. Effective communication means that there's a sender and a receiver, right? The person sending is giving the information, and the receiver is understanding what the person is meaning. And then there's a reflection. You send it back so that there's understanding has occurred. So that understanding has occurred, right? Because otherwise, it means nothing. There is so many distractions, so many things that can negatively affect communication. I think of external noises being, or distractions being noise and the devices that we use, and maybe even the patient themselves chatting as you're trying to talk with somebody else. But internal distractions could be like someone walked over the top of you. You're on the radio, you're talking, and somebody else keys up the mic, and that messes up the communication. It bogs you down. Okay? So we got to be thinking about that as we're doing radio communications. Now, we also primarily are going to be talking with the patient. You need to talk to them as you would your grandmother, as you would your grandfather. Hi, my name is, right? And you have to practice that approach. You can't just come into it going, yeah, I just need to do that. No. Hi, my name is EMR Robertson. I'm with the rescue squad. I'm here to help you today. Is that okay? What have I just asked for? Consent, right? We talked about that in the last chapter. What's your name? What would you like me to call you? right? And then use ma'am or sir as appropriate, unless they say, well, call me so-and-so, and I'm not a ma'am, or I'm not a sir, or whatever else. And remember, we're not judgmental. Whatever they want to be called, whatever. It doesn't matter. We're there to help them, not for us to push an agenda. Make sure you keep eye contact with them. It helps them to understand that you're paying attention to them. And kneeling down is always good. Put yourself at their level, whatever that level may be. You want to use language the patient can understand, and you want to speak slowly and clearly. You want to talk over to the fast because that's not going to help. And you don't want to talk so slow and soft that they don't think you know what you're talking about either, right? Sure. Make sure you're telling the truth. This is not a time to lie. One of the things you need to get used to saying in response to this question, are they going to be okay or am I going to be okay? Here's what you need to say. We are going to do everything possible for you. We're highly trained individuals. Because we don't want to lie, because we don't know the truth, if they're going to be okay or not. So we're going to do our best with that, right? We're not going to lie to them. Because if we're caught in a lie, they will not tell us anything from that point on. When we ask a question, especially to the elder patients, to the geriatric patients, we have to allow time for them to digest that information and give it back to us with the answers that we're looking for. We cannot just assume that they're dumb, that they're slow, that they're just not hearing us or whatever. Allow for a moment of response. The people talking with the patient, interviewing the patient, needs to be limited. I prefer one. Now, there may be times when somebody needs supplemental information and they need to weigh in, but be careful because then you're distracting them. Your body language, arms crossed, rolling eyes, irritated voice, it's not going to get as far as an open stance with your palms forward and you're talking in a calm tone and everything is good and everything is fine and everything is wonderful, right? We have to be aware of what our body language and what our sound language is portraying. Are we acting like this is the end of the world as we know it? It's the end of the world as we know it. Or is this, hey, I'm here to help you. What can I do for you today type of communication? Some of the things we may not have to deal too much around here with are cultural norms. We have a Hispanic culture, and that is for sure. We could spend an entire class period speaking to that effect, that alone. If you plan on going to Chicago or Detroit or Lansing, these bigger areas have other cultures that are kind of woven into the tapestry of the community. And you're going to have to understand, what does it mean to help the Islamic community? What does it mean to help a Hindu community? What does it mean for, so you have to be aware of the demographics of your certain area, your coverage area, and be able to respond to their needs in that moment. While you're communicating, use open-ended questions and closed-ended questions appropriately. Open-ended. So tell me what you're feeling today, right? It forces them to think about what they're doing. Have you had problems before? That's a yes or no. A yes and no question, that's a closed-ended. There's only two right answers, right? Yes, no, right? And if you keep this in mind, if you treat all patients like they're someone that is in your family and you love your family so much that you don't want anything to happen to them, well, then that is a great way to begin your communications with your patients and other people, quite frankly. Now, when we talk about patients who are hard of hearing, what? Or deaf, they're not dumb, okay? I want you to remember that. They're not dumb people. So you need to identify yourself by showing your patient your badge or patch or whatever. You might have to just kind of put your hand on their shoulder or touch their hand to get their attention. A lot of people with hard of hearing will look at your mouth because they're trying to hear pieces of it, and they're trying to read lips as well that kind of go along with that. But when you're talking with somebody that can't hear very well, shouting is not going to help because it distorts your voice. But you may need to speak a little bit more distinctly and slowly so that they can utilize what they do see and hear and form some coherent thoughts about what you're asking. And also be watching the patient's face for recognition. Are they with you all the way here? Sometimes you may have to repeat what you've said, what you've asked. You might need to rephrase it in simple language because our technical terms are hard to understand, especially if they don't know medical. And then, quite frankly, if all else fails, write down your questions and you can go back and forth on paper. Now, patients who are visually impaired, you're going to have to tell them what's going on, especially if you're cutting a car up around them. That's scary. Or all of a sudden you're moving them and they don't know what was going on. They might reach out trying to stabilize and hurt themselves. Always describe what's going on to them. And try to use their name, especially for the visually impaired, so they know that you're talking to them specifically. If the patient has a service dog, attempt to keep the animal with the human, because the animal is trained to that specific human. Now, for those with special needs, the visually speaking, you don't need to talk louder. But it is human nature to think, well, they've got a problem. Maybe it's hearing it in nature. No, it's not always hearing. Sometimes it's visual. This is a very tricky thing, the non-English speaking patients. You might have to get a translator, but I will tell you that knowing some key phrases, donde le duele, me llamo es, where you hurt, my name is, ayúdame, I'm going to help you, or help me. These are things that you might want to start learning. But we also have Google Translate, which does a decent job, right? You might use your hands to kind of point to things as well. And again, I talked about this a little earlier. Don't assume geriatric people are old, or that are old are just stupid, or they have hearing problems or whatever else. You see them, talk to them as normal. Assume that they're normal, right? And give them time to respond to your questions, to your actions, so that you're not denigrating. In the same way, pediatric patients react differently, and no amount of you coming at them and making yourself at their level is going to put them at ease. Maybe you want to help them to answer questions by stuffed animals, their stuffed animals or whatever, and try to talk to your patients specifically, but if not, enroll in mom and dad in this discussion of what's going on as well. Maybe the parent holds the child during this exam. Obviously, when you go to transport them, you're not transporting, the EMTs are, but you're going to have to make sure that everybody's secured. And always tell a kid what you're doing before you do it, because it's scary. These big old meat claws coming at them, they may not understand what's going on. As with the adults, get down to the level as humanly as possible, if at all humanly possible. Make contact and be honest, because the kids, they're not dumb. They may not understand the words, but they're not dumb critters. They can figure things out, right? We also have patients who are developmentally disabled. That could be cognitively, that could be physically. And when you're dealing with those, there's a caregiver there, whether it's a family member or a long-term care facility. Use short sentences, simple words, and speak slowly. Again, you might have to repeat, and maybe you're not going to get any response from the patient at all. Maybe this is just you having to deal with the caregiver. Or maybe you don't even have that. You just have to do a visual inspection. In either case, in any case, compassion saves the day. Now, there are those that will be displaying disruptive behavior or behavioral emergency that looks like they're going to try to hurt somebody, including themselves. We need to assess the situation and determine if this behavior is something that is being caused by an event, like it's trauma, they got a head injury, or a medical event, like they're diabetic, or if this is them just flying off the handle. In any case, protect yourself. The patient needs to be protected as well, but you need to protect yourself. And never put the patient between you and an exit. Probably the scariest thing ever is that happening, and they're not quite right in the head. Do not take your eyes off the patient or turn your back. Again, if they're being disruptive, that could mean the difference between injured and uninjured for you, or life or death for you. And definitely, if the patient has a weapon, back the crap up. You are not law enforcement. I mean, some of you are, but let them do their jobs. And then, as soon as your personnel are safe, then you can carry out your appropriate medical emergency care. The appropriate emergency medical care. I said that backwards, I think. Anyway. By the way, just because they're disruptive doesn't mean that they're altered. Because they can be just jerks. If they need to go get looked at, if you think they need to go get looked at and they don't want to, I would use law enforcement here to kind of scare them in. Hey, you're either going with me or going with them or whatever. I mean, you see what happens, right? Communication also is medical terminology. Can we understand the parts of the words that we use? And there's a ton of them out there. A metric ton. There's an anatomic parts that we need to know. There's illness and injuries that we need to know. And there's treatments given. Now, with these, there are specific names for them so that we can communicate effectively to the next care group. Hey, this is what's going on. Yes, plain language works wonders, but not everything is identical. And so we might have to use some of our medical terminology to be very specific about what's going on with this individual. Because our job is to communicate our message to other medical providers as clearly as possible so that they get the best possible care, right? And if you don't know what the medical term is, don't use it. If you don't know the meaning, don't use it. When you get something new that you've come across, why don't you make a list of things in your little notepad or your notes so that you can review those, right? And then some of this is about just rote memorization. Have you looked at some of these things? Have you put them into your memory banks? Here's a good one. Some very good things. I would write these down. I would keep this as a cheat sheet in my back pocket if I was you. Then we get into documentation. Now we talked about this a little bit in medical legal, but this is the proper report, or the report proper, I should say. Most of it is going to be computer based, and it is used to record demographic information, history of the complaint information. What did we find? What did we see? What did we do? How did it turn out? Who did we hand them off to? Right? Because we need to have all of this stuff ready to give to the next level, right? Little words are hard. Patient's chief complaint is what the patient tells you is wrong, right? The patient says, I have a hurt toe. So the patient's chief complaint is hurt toe. Even if their arm is hanging by a thread, The chief complaint is what the patient says. Now that then goes to patient's level of consciousness. Are they awake, alert, and oriented to person, place, time, and event? I call that AO4. Awake, alert, oriented to person, 1, place, 2, time, 3, event, 4. AO times 4. If they're not, are they responsive at all? So we finish up with AVPU. AVPU is the alert. So if I'm thinking AVPU, the patient's responsive to verbal stimuli. Meaning if I yell at them, there's some sort of a response. Not maybe conscious, but responding. P means painful stimuli. So yelling didn't work, but I take my knuckles and grind them into their chest and they kind of flinch back. They're said to be responsive to verbal stimuli. And then finally, you have the unconscious, unresponsive that don't respond to anything. You knuckle down on them and nothing goes on. So what's the level of responsiveness? What were the baseline vitals, repeat vitals? What did I find in my physical examination? My sample history, signs and symptoms, allergies, medicines, past pertinent history, last oral intake events leading up to. What did I find, right? And what did I do for this patient? All of this needs to be documented. Was there any change in the patient's condition? Did they get better? Did they get worse? Who took over for you? Was it another ambulance agency or did you leave them with another EMR agency? What time did those people get there? Okay? And what time did they leave? What time did you leave the scene? Again, we need to document any mandatory reports. You can go back to chapter 4 for that, right? Or is it 5? You can go back to chapter 4 for that, because this is chapter 5, about those mandatory reports. But we need to talk, that could be a different written report altogether. But your PCR, your patient care report, has to be filled out as soon as possible, because the next layer of care is going to want to have that, and they can access that remotely. Okay, so here we're at the end of the communications documentations. You just need to think about some of these things, right? How do you relay information? The communication system is that way of doing things, right? Whether it's a face-to-face is the best way, right? But the systems are in place when we can't be face-to-face. Excellent communication skills are crucial during every phase of the call, whether it be at the very beginning, in the middle, or at the end. I've got to be able to effectively communicate with somebody so that they can understand exactly what is going on. You need to know how your department communicates and what kind of systems they have. You must be familiar with two-way radio communications. How do I press the button and talk, right? And most specifically when we're talking about handheld radios, how do you use them in an effective way, right? What kind of communication systems do we use? And how do we update dispatch? What do we need to tell them? What do we do at the scene? What do we do with the other EMS units? How are we transferring cares? What do we do after the run? What do we do in the communication portion of our call, right? It's also important that we know the standard procedures and protocols used by our departments for the community communications for the communities that we serve. Along with radio and oral communications, you need to be able to talk person to person, because body language and attitude are spectacularly important. You've got to be able to talk to people of all nationalities, ages, and communication styles. And then finally, along with your radio report and oral report, you must complete a formal written handoff report to give to the next level, whatever that next level may be. Remember, the call is not over till the paperwork is completed. And that, friends, is chapter 5.